Welcome everybody to our chronic pain webinar series. We're actually going to have a set of three webinars, all led. Sorry, I should introduce myself. I'm Amber Rogers with Mountain Pacific Quality Health, and my colleague Stevi is a PharmD, and she's going to be leading us through the next three sessions that we have scheduled. If you're registered for this one, you're automatically registered for the other two webinars in this series. And we're going to really concentrate on some of those prescribing practices to follow the CDC guidelines related to opioids. And Stevi has a wealth of knowledge in working not only as in the clinical pharmacy situation. So we're glad to have her. And with that, if you want to go to the next slide, Stevi, I have a couple of disclosures. This was put together using some grant funds from the Rural Opioid Response Project here in Montana. And if you are a nurse, this also applies. You can get education credit for this. You do need to attend the full hour, and you also need to fill out the evaluation form and put your name on the form so I know to whom to send the certificate to. So with that, I have nothing else. We don't have any conflicts of interest in putting together this educational series, and I will turn it over to Stevi. Thanks.
Thank you, Amber, and thank you everybody for being with us this afternoon or morning, depending on where you are at in the world. Today, we are going to spend some time really talking about the Centers for Disease Control and Prevention opioid guidelines and best practices. Those primarily relate to chronic opioid use for chronic pain management. We're going to briefly discuss the opioids' role in acute and chronic pain management, what that looks like, maybe where we should and shouldn't use an opioid. We're going to talk about the morbidity and mortality that comes along with using opioids and central nervous depressants in combination. And then we're going to discuss tips and tricks and tools to help use shared decision-making to set our pain management goals. In acute and chronic pain, those conversations can look very similar. You just have more of them when you deal with chronic pain. So I wanted to kick us off by talking about the pharmacology of opioids. Opioids work by binding some receptors that we have all over our body. The primary purpose of this is that we want analgesia, we want relief of pain. But because those receptors are all over our body, they have endogenous or like in your body functions, things that are natural. And so when we're binding to those, that can have some unintended consequences. And that's where we start seeing our adverse effects. So typically when we talk about these, you can see them called mu, delta, and kappa, or sometimes they're called like MOP, DOP, KOP, depending on what research you're looking at. The MOP nomenclature is maybe a little more current. It just depends, like I said, what you're looking at. But we primarily talk about mu opioid receptors. When we talk about opioids, this is really where we get good analgesia for pain. You also can get on the delta receptors, you can get some spinal analgesia. So that's where things like nerve blocks, lumbar epidural, those things can reduce pain. But also when we start binding to those things, you'll notice like with the mu receptors, you get sedation, vomiting, respiratory depression, which is what we really worry about in the event of an opioid overdose, itching, euphoria. So that's what leads to that abuse potential, anorexia, urinary retention, physical dependency. Because we express these all over our body, we see a wide range of results when we manipulate them, when medications bind to them. And this contributes to the way that our body builds tolerance, but also how we develop those addiction pathways and alter our neurochemistry. So this is a pretty simplistic picture of what happens at a cellular level when an opioid binds an opioid receptor. So morphine is the example here, and it causes a cascade that makes our cells react in a certain way, right? It changes the way we regulate GABA, it changes neurochemistry, and it also changes the expression of these receptors on the cell. So when you just use them for a few days in acute pain, we see fewer of these cellular changes. But when we start using them long-term, like for chronic pain management, we really start to see the changes in expression of receptors and the way that the neurotransmitters are released. And that starts leading us down the pathway of things like hyperalgesia, increased tolerance, dependence, whether that's physical or mental dependence. You can have both with opioids. Those are not necessarily signs of misuse or abuse, but they do tell us about how the patient's individual body is reacting to the medication, and it gives us some clues on how we should proceed as we manage their pain going forward. So those are all things we're going to keep in the back of our mind as we move forward and talk about opioids. During our series, we're going to talk about acute versus chronic pain. Today, we're primarily going to focus on chronic pain. Later in the series, we will focus on acute pain. There are some important differences in how you manage those two things. When I was looking at the different definitions that are available for these, it's highly dependent on which source you use, what the definition would be. And you'll notice in my slide here, there's definitely a gap that can occur. So acute pain, according to the Centers for Disease Control, is often defined as lasting less than 4 weeks. And then chronic pain is pain that typically lasts longer than 3 months or past the time of normal hearing. So what you are between week 5 and week 12, the CDC does not really tell you. And that gives you a little glimpse of some of the gray areas that come into play when we are practicing medicine and dealing with pain. Not everything is cut and dry. When we're talking about chronic pain, it's important to know that while that can be the result of an underlying medical condition, an injury, treatment, inflammation, those sorts of things, typically there's no acute injury. As it says in there, normal healing has happened. We have reached sort of homeostasis for that, and then have to move forward with what the physical presentation is for the patient at that point. So when we talk about the CDC guidelines for prescribing opioids in chronic pain, this document came out in 2016. Likely most people are pretty familiar with it at this point, but it is helpful to get a refresher. Often I find that I refer back to the guidelines when I'm working in the pharmacy. So I think probably as like a baby blanket, but this is a nuanced and important subject. When we are treating chronic pain, we are impacting patients' quality of life. And so there's a lot of pressure to get it right, to first do no harm, but also provide good support and relief to patients as best we are able to in our healthcare system. And so having tools in our toolbox that help us refer back to best practices and standard of care, particularly when we talk about something like opioids that are very heavily regulated and at times very controversial, can protect us as providers, and also ideally will improve the quality of care we deliver to our patients. The guidelines developed by the CDC are primarily intended for use by primary care providers in an outpatient setting. That can include nurse practitioners, physicians, physician assistants. It's not typically geared toward board certified pain specialists or people who are practicing addiction medicine. However, it can definitely still be utilized in those settings depending on the needs of the patient and the practitioner. It is aimed for patients 18 and older with pain lasting longer than 3 months. You should not apply these guidelines to things like active cancer treatment pain, palliative care, or end-of-life treatment. Obviously, when we're trying to keep someone comfortable at the end of their life, the rule book is different, and our focus on reducing the risk of misuse and abuse and dependency and all of those things change based on what the patient is experiencing. So please keep those things in mind. Also, these are not hard and fast rules. It is a guideline. It is something to help us make clinical decisions, but not something that is completely black and white and applies to every single situation. It's important if you are dealing with an individual patient to treat them like an individual patient, and when possible, rely on all of our tools and resources that could include additional guidelines from specific organizations for a certain kind of pain. Say like if you have an arthritis type issue, you can work with osteomedicine and those sorts of things. There are other things we can rely upon, which includes our peers. So that's totally a great, resource to rely on if you have someone who's experienced in pain management. You happen to have access to a pain management specialist, and they are able to be brought on when you're having a difficult consultation on a patient. Those are things to consider as well. The guideline is structured. It is 12 recommendations grouped into 3 areas. So we have initiating or continuing opioids for chronic pain, your opioid selection, including dose, duration, follow-up, and when to discontinue, and then assessing for risk and addressing harms of opioid use. I think this is an area where this guideline was very powerful when it first came out. It provided a lot of good standards of practice when it comes to assessing risk and addressing harms from opioid use, and started changing the conversation. Many of us practiced in the time of pain is the 5th vital sign, which really encouraged people to try to treat pain to a level of no pain, which is likely there are trade-offs. When we make those decisions, we reduce function for patients and can impact their quality of life in a negative way. So that risk assessment is important. But when you start off, you're looking at initiating or continuing opioids for chronic pain. One of the things that happens with opioid patients, obviously sometimes they move, providers retire, they choose not to see a provider any longer, and we might not be starting fresh with that patient. We might be continuing. It's important to assess at all times with those patients and periodically, even if the patient is yours. The very first guideline in this tool, the very first recommendation in this guideline is that opioids are not first line for chronic pain. Opioids actually do a pretty bad job of treating pain for many patients. And that is because when we have healed tissue, the way our body is expressing pain is probably not specifically related to those opioid receptors, the mu, kappa, and deltoid receptors we were talking about, delta receptors we were talking about earlier. There are many things that come into play. You can have muscular pain, you can have skeletal pain, you can have nerve pain. And so when we approach chronic pain management, it's important to start drilling down into what specifically is impacting this particular patient and approaching it from a multimodal strategy. So looking at optimizing lots of different therapies and regimens, and that should absolutely include non-pharmacologic therapies, things like stretching, yoga, aromatherapy, massage, physical therapy, OT. Those things absolutely can impact patients very positively, can reduce their need for pharmacological therapies, reduce their pill burden, improve their quality of life, and help them achieve patient-specific goals. One of the great things that is happening in medicine is that we're really starting to ask patients, what do you want from the interventions we are choosing? And it includes things like, I want to attend my grandson's graduation. I want to be comfortable enough that I can sit in the bleachers at a basketball game. I want to be able to dance at my daughter's wedding. Those are things that so powerfully impact a patient's quality of life and are not often measurable in terms of we're throwing you on a scale and we're getting a number, or we are giving you a chart and we're asking you to rate your pain from 1 to 10. Those hard to quantify outcomes are likely what is most important to patients. And this is why opioids should not be first line, and they can't be monotherapy. Opioids come with trade-offs, like I mentioned earlier, when we talk about sedation, risk of respiratory depression, those sorts of things clearly can impact quality of life. And so there's always that risk versus benefit balance. And when we do use opioids, again, it should be done in combination with preferred therapies. We have to establish and measure our progress toward goals. Those goals should include some medical goals, especially pain can be expressed in lots of ways. We can see it in hypertension. We can see it in irritability, fatigue. There are definitely medical milestones we should consider, but having those good conversations with a patient to find out about their personal lifestyle goals are very important as well. And those prove to be a really valuable benchmark so that the patient buys into their therapy as well and feels like things are working, because unfortunately, we cannot set a goal of my pain will be 0. That's not a realistic thing, particularly not in the presence of chronic pain. The focus has to be on making it manageable. Then we have to discuss the risks and benefits with the patient. There are going to be trade-offs, there are concerns. This should be an individualized conversation. It should reflect the current health of the patient. Talk about things like sleep apnea, current function, whether or not they exercise. There are many risk factors that should go into evaluating their individual risk. And we'll talk more about that in a little while. So that moves us into the second sort of grouping of recommendations. And this really centers around how to select an appropriate opioid product. And this was, again, is a change in thinking of some of the past. When I graduated pharmacy school, we really tried to move people to long-acting abuse deterrent opioids, thinking that that would provide them more adequate pain relief while keeping them safer. However, the literature doesn't support that. When we look at actual patient outcomes and what happens to patients that are on opioids, we find that we should always use the lowest effective dose. We have to look at the morphine milligram equivalents, ideally keeping those below 50, which is actually a pretty low morphine milliequivalent. It's the equivalent of just a handful of hydrocodone pills. And we want to use immediate release opioids, particularly at the beginning of treatment and whenever possible. One, because it helps us keep that morphine milligram equivalent low. And when we give patients those immediate release products, there are fewer cases of bad outcome, such as breathing emergency, overdose, or death. So, and I do have some of the recommendation categories and evidence types up there just to explain those to you guys. A category A recommendation applies to all persons. That's the recommended course of action for most patients. And then you might see a category B later in the presentation, and that is where you need to make an individual decision. Different choices are appropriate for different patients, and the guidelines do have some breakpoints to help make those decisions when you're evaluating a specific patient with a specific clinical need. And then the evidence type that you see there is a grade. Type 1 would be a randomized controlled trial. That's our gold standard. Type 2 is a strong observational study. 3 is a randomized controlled trial with notable limitations. And then 4 is an observational study or clinical experience. So this one is about clinical experience and primarily observation studies because most of our opioids are relatively old and we don't have a ton of randomized controlled trials being conducted on them at this time. Some of the newer agents do go through that process, but very rarely do you see pharmaceuticals in a category being compared head-to-head. When we talk about opioid recommendations and the selection of a product, we also have to consider when an opioid is not appropriate. And this is where we start evaluating the benefits and harms. And here are some good benchmarks for us when we're considering a taper. You're going to want to evaluate your benefits and harms within 1 to 4 weeks of initiating therapy or of a dose change. And we should be reevaluating a minimum of every 3 months. Ideally, we're going to be seeing these patients more frequently than that. And this is something that represents both a patient burden and a burden to the provider. And so it's something we have to be aware of and talk about when we talk about those risk versus benefit conversations and patient goals. If you have chronic pain and you're going to be on an opioid, you are going to be seeing a lot of your provider. And it's important to have those conversations so that the patient can plan for that and decide whether or not that is for them. If the benefits do not outweigh the harms, say they're having a lot of lethargy, they're not able to complete their activities of daily living, they're falling, they're sedated, they can no longer drive. That is a time where we would really want to consider tapering that opioid to a lower dose or discontinuing opioid therapy altogether, particularly if we aren't seeing a corresponding benefit to their pain management goals. There are lots of different approaches to tapering. These are just some examples. Rapid tapers were conducted often in patients where there were concerns in the past. Hopefully we're not doing this anymore. I'm not a big proponent of rapid tapers. They're painful for patients. They can cause a loss in their confidence in their healthcare team. The patient can lose trust in the healthcare system. Rapid tapers are not ideal for most situations and should only be done in times where there truly are no other options, or in cases where there are severe adverse events such as an overdose and the patient, there's no other safe option for them. It really should be a rarity. Moderate tapers reduce the weekly dosage by about 10 to 50% until it's discontinued. It's important to check in with patients when you're doing tapers to make sure they're not experiencing a lot of adverse effects. Withdrawal is an adverse effect. We should try to avoid it, again, because it causes the patient to lose faith in the healthcare system. It's painful. It can cause mental health concerns, bring on acute depression, anxiety. It also, causes nausea and vomiting and just really is hard to function. So you want to try to avoid that as you're tapering. The goal with tapering does not always have to be discontinuation. Sometimes we're just looking to reduce the dose until we see an intolerable side effect disappear. So decreasing sedation, making it to where they can complete their activities of daily living. They're not falling, those sorts of things. There are other times when we're not seeing any pain relief benefit, and that is when you should just completely go ahead and taper. In our 12 recommendations in the guideline, the last probably 5 of them are around assessing risk and addressing harms. I am a big fan of implementing opioid risk assessment tools as a hard stop in your electronic health record. It is when you are pressured to see many patients in a short period of time and make quick clinical decisions, there can be opportunity to sort of miss key conversations, like tell me about your family history with alcohol, or, you know, do you personally have concerns about misuse or abuse of a medication? These just give us an opportunity to have a safety net in place so that we have to go through those. The ORT, the opioid risk tool, is a very short questionnaire. It's designed for patient self-assessment. This is a thing you could even have the patient do as they check in for an appointment if you know they're being seen for pain. The DIAR is another one that is designed to help guide decisions around appropriate long-term opioid analgesia. So you can find one for acute pain. You can also be more tailored toward long-term pain management. There are lots of options out there. Most of these have been well studied, so they are evidence-based. We know that they work, and there are ways to implement them that doesn't increase the burden or the amount of time that the provider is required to be in the room. You can gather these during initial check-in with, you know, just assistance of your MA, your nurse, or like I said, you can even include it just on the patient portal or an app. Say if you use the Frisia system, you can have them fill it out there when they're checking in. And then I also like to talk about the CALM. This is a tool. It's a 17-item patient self-assessment that's designated to take less than 10 minutes. It does require truth from patients, but again, this is something we could use when we're doing those 3-month evaluations of a patient's pain regimen. This gives opportunity to look for possible side effects. It screens for memory problems, insufficient pain relief, thoughts of self-harm, time spent thinking about taking their medication, signs and symptoms of depression, anger, and it also questions about misuse and diversion, like are you borrowing meds from others? Do you have concerns about obtaining your medication? And just really allows us to capture more information to take complete care of a patient. I have heard from some of my providers that I work with that occasionally it's hard to ask these questions because once you find out the answer, you have an obligation to do something about that. And sometimes in our rural areas where we don't always feel connected to tools and resources, it can be daunting to know what to do if you do discover that your patient is, say, borrowing meds from others, or you know, you're able to gather information and they trust you and they let you know they're misusing it, or you see other indications of addiction or misuse. That can be overwhelming, but ideally, as we have more of those conversations, we get more comfortable with them, and this becomes part of standard of practice. Because when we talk about opioid analgesia, we also have to always consider, how will I get the patient off of this medicine at a certain point? Because these should not be lifelong medications. And what do I do when they develop dependency, because they will, and how will I handle it if we cross into addiction? Morphine milligram equivalents come up all over the guidelines. There are risk stratification levels. Below 50 morphine milligram equivalents is considered a low or mild risk for primarily a breathing emergency, respiratory depression, overdose. And then we go from 50 to 70 is our next breakdown, and that's where we have moderate. And then up to 90 is our high risk, and anything above 90 is very high risk. You should really start thinking about, why are we doing this? I also like the app because I mentioned I like to go back to these guidelines and think about them in my pharmacy practice. And the app lists all of the recommendations, and you can click into them and you can read the key points. And it has a morphine milligram equivalent calculator on there. This one is nice because it will allow you to add several different medications so that you can get a complete MME for the patient's daily pill burden. So say you have someone on Oxycontin, Percocet, and they happen to get some Tramadol, you can look at that whole picture and see, okay, as we layer these, what is our risk starting to shake out to? And it has some caveats in there for you about some of those CNS depressants. And this is a very important thing to think about, because a patient who's on 45 milligrams of a morphine milliequivalent, in theory, is at mild to low risk. But if you also know that patient has COPD and they take anxiolytics, so they're on benzodiazepines, and they take an Ambien to sleep at night, that really changes that risk assessment. We know as we layer on those CNS depressants, we increase the risk of an adverse outcome for a patient. That could be a severe fall, but most often what we're talking about in those situations is we are increasing their risk of a breathing emergency, having acute respiratory suppression to the point where the patient can lose their, when we add all those things on, we are closing down their instinct to breathe, and we are slowing the respiratory rate and they'll stop breathing. So that is how people die from opioids. There are lots of conversion factors out there. The CDC uses, the most common. You will find that for some things like buprenorphine and methadone, there are many different conversion factors. That is because not every opioid is a straight agonist on those receptors. Some are antagonists as well, and that changes the way that they react with the body, and it changes dosing. Methadone is one that it's very important to know what the breakdown is of their dose, because as we titrate methadone up, the way our body is able to break it down changes very dramatically. And as you layer on more methadone, it lingers longer, and that morphine milligram equivalent goes up. It also can be unpredictable for many other reasons. Methadone is tricky. I would recommend working with a specialist who is comfortable with dosing if that is what is the right medication for your patient. Most other things are pretty straightforward. You can see on here like codeine. 1 milligram of codeine is equivalent to 0.15 milligrams of morphine. This just gives us a nice way to compare apples to apples so that we're not trying to figure out how 8 milligrams of Dilaudid is at risk for a patient who was previously on 80 milligrams of Oxycontin. It helps us really to bring things in, and it just becomes math, which is helpful in clinical decision making, especially if you have a patient who is on long-acting medication that now you're wanting to taper and move to a immediate release formulation. This helps with all of the math there. And there are also a lot of tools in the literature that you can look at that help move patients from one medication to another. when we talk about using these guidelines, the most important thing is that we are adopting appropriate pain management components. And there are lots of different policies and opinion statements out there from lots of different professional organizations. I really like the guidelines for chronic use of opioid analgesics from the Federation of State Medical Boards. This is a very thorough document that really clearly outlines what we should do to provide adequate care, and really outlines a nice standard of care. And coincidentally, this is a document that is supported by the DEA. They did not help develop it, but if you talk to a DEA agent, they feel like this is a good, comprehensive standard of care. And these are the sorts of things they look at should they decide to do an audit of an individual's practice. So here are some components. There are lots in the actual document, but I pulled out these ones. These are different components of appropriate pain management. You'll see again that emphasis on patient evaluation and risk stratification. You need to know where your patient is at baseline before you determine next steps. Like, that is how medicine works. That patient evaluation should be dependent on the type of pain, obviously patient specific, and you need to know what system to look at. You need to do a complete systems review, a physical exam, laboratory investigations. And if you've ever worked with a pharmacy where they need these results as part of their policy to be able to fill something, this is why there's that corresponding responsibility to make sure the prescription is an appropriate prescription and legal. And this patient evaluation is the cornerstone of making sure that an opioid prescription is legitimate. We also have to start looking at the patient's supports and obstacles, their social supports, their housing, meaningful work. This plays into their risk for addiction and dependency. And then we need to investigate personal and family history of addiction and abuse. We know that a personal or family history of abuse is very, very closely tied to risk for development of addiction and abuse of opioids. They also have a good outline of what is inappropriate management in these guidelines. So it talks to you about, like, did you have an inadequate initial assessment? We always have to answer the question first, are opioids clinically indicated? If we didn't do a thorough exam, we cannot determine that they are indicated. If you skip that step of looking at an individual's patient's risks associated with opioid use, such as do they have underlying conditions that increase their risk for breathing emergency? Do we worry about falls and sedation? Those sorts of things. We are missing important steps. And then we have to continually monitor for misuse, abuse, and insufficient improvement of function. Just because it is easy to take a pill, if it's not working, we should not continue it. And I know all of this seems very silly when you spell it out, but we have all been there where the pressures of the day mean that things fall through the cracks. So it's nice to just have these, and I would encourage you to consider a policy for any clinic that you are working in that really outline these expectations very clearly so that it can be standardized, so that everyone sort of approaches things from a documentation standpoint on the same level. And then it's important to talk about patient education and informed consent. If we are going to talk about shared decision-making with patients, they cannot share in the decision if they are not fully informed. They need to know the knowledge we have in order to make the best decision for themselves. So we need to clearly outline risks, outline the limitations of opioids in the treatment of chronic pain. Going back to that conversation of zero pain is not a realistic expectation. Finding out what trade-offs the patient is willing to make to achieve the best function that they can, and then really discuss their individual risks, so any conditions that might be worsened by opioids. I'm not going to talk about the prescription drug monitoring program today, just so you know. That is a valuable tool in comprehensive pain management as well. We will talk about it in detail later in our series, and so that's why it's missing today. But do know that using that PDMP, checking it, using it as a clinical decision tool is also something that needs to go into all of these things, but we will cover it in detail later. So then you're finally to your treatment planning. You're looking to individualize treatment goals, talking about what is reasonable, what is an acceptable trade-off for a patient, do they have unacceptable side effects? This is something that my provider does that I always appreciate. Nausea and vomiting is an unacceptable side effect to me for most medications, and it's nice to just get that out there. She knows I would rather not pick if there are options to where that is not a risk. Patients have those experiences where, because life impacts us, different people need different things. And so getting to know your patient, talking to them about what is acceptable to them and what is not is very important. Risks and benefits. You need to talk to them about addiction and misuse planning, what that looks like, how people get there, what they should do to avoid it. That can include things like take your medication as prescribed, make sure they clearly understand their directions. You would be amazed how many different ways a person can interpret, take 1 to 2 tablets every 4 hours. When you talk to patients about those things, it's very important to use a teach back so that they can tell you back what you said so that you can clear up any discrepancies, because that is a fact of medicine. People don't always hear what we think we said. You need to talk to them about overdose and what that looks like. There should be overdose planning, particularly if your patient does have risk factors. Ideally, that overdose planning will include another member of their household, because someone who is experiencing respiratory depression and a breathing emergency likely cannot administer their own Narcan. Talk about your prescribing policies and expectations, what you need from the patient so that they have full disclosure, like I need to see you every 6 weeks for a while, and then we'll move to every 3 months, and I'm going to check in on you. Setting those expectations up in advance is very important. And then talk about reasons why treatment may be discontinued. I would encourage people to consider misuse and abuse should not necessarily be on that list that treatment will discontinue. Treatment should change if we develop addiction, misuse, abuse, those things. There should absolutely be change, but that should not be a reason why we fire a patient from our practice. That should really be an action of last resort, if at all possible, because when someone has developed a mental issue, which addiction is, you should not abandon care. We should ideally get them the care that they do need. So treatment discontinuation should be for things like inadequate pain control, risk of sedation, falls. We're not getting the functional improvement that we need. When you are assessing a patient, the 5 A's come from that Federation of State Boards, state medical boards as well. I like this because it's easy to remember. We look at analgesia. Are they experiencing reduction in pain? Look at activity. Do they have improved function? Affect. How's their mood? When we start changing the neurotransmitters in our body, one thing we always think about, or at least I do, when I think about neurotransmitters, is I think about depression, anxiety. We know those are neurochemical imbalances for most folks. And so when we change the biofeedback systems of the body with a substance like opioids, we can change that balance. Are we having issues there? And then really ask about adverse effects and aberrant substance-related behaviors. So are you tired? Are you sleepy? Are you able to make it to work every day? And then are you clock watching? Are you struggling to take your pills as directed, those sorts of things. You can't talk about opioids in chronic pain without talking about harm reduction and naloxone. When we look at people who are at an increased risk of opioid overdose, it includes a lot of our patients that are on chronic opioids for chronic pain management. People who are taking a high MME, so this would be above that 50 MME daily mark. Again, receiving overlapping opioids and benzodiazepine prescriptions, that is a huge risk factor for an opioid overdose. Anybody who has mental illness or a history of alcohol or other substance abuse, so many of our patients fall into this bucket. It's important to protect them. And then because this is our core, and we're talking about Montana, all of our patients live in rural areas. Thankfully, not everybody has a low income, but that access to care can really impact their risk, especially because I practice in Wyoming, and when new regulations started coming out about limits to prescriptions, the amount of time we could give for an acute initial fill, there were some valid concerns about patients' access to see a provider again, to renew their prescription, and we were reluctant in my state to limit people to just a couple days of medication, so we gave them more, and that increases that risk of overdose. You also have to watch for people who have recently completed opioid detoxification or abstinence programs, people who were recently incarcerated with a history of opioid use disorder. When we are abstinent from opioids, those receptors that are present on our cells change. So they move up and down depending on our exposure to opioids, and that decreases our tolerance to opioids. And so people who previously could handle one dose of oxycodone or heroin or whatever their drug of choice, there might be, it changes, and what they were used to and felt like was safe before and gave them euphoria or helped them be normal, which is more often the case with opioid addiction, now can be deadly. So those folks are really at increased risk. And all of these patients should be offered and encouraged to get naloxone. Naloxone just competitively binds to that opioid receptor. It is powerful enough that it will knock the opioids off of the receptors and bind instead. It is an antidote to acute opioid toxicity. With proper education, it can decrease the risk of fatal breathing emergency. Ideally, you would train your patient to still let you know so that you can talk about risks, because it indicates there needs to be a change. It comes in several different forms. The naloxone kit containing naloxone syringes and sometimes needles or sometimes a nasal aspirator, aerosolizer rather, so that you can squirt it in the nose, or if they're trained, they can inject it, is the most affordable option. There's also the Narcan nasal spray. I happen to carry that all the time because in the state of Wyoming, you can have one if there is a chance you can encounter someone overdosing. And in the location where our office is, there is a large homeless population. And so when in doubt, carry it is my sort of, I guess, Boy Scout attitude as a pharmacist. And then there's a Vizio as well. This is the most expensive, but if you've ever had a chance to work with one of these devices, they work incredibly well. In an emergency situation, many people who are not trained panic and freeze, and a Vizio walks you through how to deliver naloxone in the event of a breathing emergency. It even will prompt you to do things like call 911. Any person who is mixing opioids with alcohol, which is a lot of patients, should have Narcan or naloxone in a kit on hand at home, and people who are taking opioids for greater than 30 days should have this on hand. We know there are some risk factors that clearly indicate a patient has a risk for a breathing emergency, but sometimes they happen and we're not really sure why. This is a good thing to have in a home kit or on the person. We should equate it to things like a seatbelt or an EpiPen. It is life-saving medication, and the risk of harm from giving it if it's not an opioid overdose is almost non-existent. Some of the suggested counseling areas when we're talking to a patient about having Narcan or naloxone on hand at home, it doesn't work if they don't know how to use it. So they should know how to prevent an opioid-related drug overdose, how to recognize an overdose or a breathing emergency, how to appropriately respond, which should include always calling 911 or going to the hospital. You should never administer naloxone and then just think the person is fine. And then conversations about how to use their product that they have selected based on their individual needs. So please feel good about giving people access to naloxone. In most of our states and territories now, it can be dispensed at the pharmacy either through a standing order protocol or because the pharmacist has prescriptive authority. It's also available for free in a lot of areas through federal and state funding. Again, it is a life-saving medication. In our Rocky Mountain area, there is a high occurrence of polysubstance overdose. And again, giving Narcan or naloxone where it is not an opioid overdose will not harm a person, but it can give us some clues about what's going on and could help. So there are also some ethical considerations that we can talk about in some of our later series, but I want the take-home message today to be, if a person is on chronic pain management, they should also receive a prescription or a kit of naloxone. With that, we've got just a couple minutes left here, and I wanted to open things up and see if anybody has questions. You can type your questions into the question box, put it in chat, or you can raise your hand and we will open your line so that you can talk.
Awesome. Thank you, Stevie, for all that great information. I really appreciate the concept of handing out naloxone very liberally. I know that there are a couple of communities that are doing kind of tracking, at least we are in Missoula, tracking the amount of naloxone that the emergency departments hand out. And it was woefully inadequate, and hopefully with a little attention to that, anybody that is being discharged from an ED should have naloxone as also a take-home medication. So just curious from the group, if people don't have specific questions, feel free to chat them in. But I was curious what you all have as a response of if you're using those opioid risk tools in your EHR. Is that embedded practice? Is that a practice that needs to have a little more oomph behind it, or a quality improvement project? Just would like to hear from the group if you could chat in what your current practices are or what practices you're trying to improve related to prescribing opioids. Don't be shy.
While we wait for people to chat in on that, Amber, I just wanted to point out a lot of our EHR vendors have modules that you can use for opioid safety. since this is a national problem, there are a lot of tools and resources out there. And often if you talk to your vendor, those forms are already built. You can customize them to your own particular practice if that is what is needed. But a lot of times it's just as simple as switching it on and then choosing when you want it to pop up. I know one practice I work with, if you select an opioid, when you go to write an e-prescription, that is when it pops up and stops you. Another, if they indicate chronic pain when they are doing their diagnosis, then a screen will pop up there.
Great. Yeah, I think some of those automatic pop-ups definitely help increase compliance.
Yeah, and it, you know, reminds you to have hard conversations when, you know, for better or worse, patients don't come to an appointment with just one concern, you know. So it helps keep you on track.
Yes, it does. Any other comments from the group or questions that we could help you with? Okay, well, thank you all for attending. And as I noted in the beginning, if you do want nursing continuing education credits, you absolutely must fill out an evaluation form and put your name on there so I know who to send the certificates to. And look forward to seeing you all again virtually at our next session, which is March 3rd, I believe. So feel free to reach out to Stevi or myself. And if you have particular questions or concerns that you'd like to have discussed in one of our upcoming webinars, because this is really to improve your practice in your local community. So thank you very much for attending, and we'll give you exactly 3 minutes left in your day. Thanks.